One of the other great things, I keep saying great things about metastatic colorectal cancer, is that our treatment options have been expanding exponentially.
That's so interesting that they are finding the differences between a left-sided or right-sided colon cancer.
Right. This question makes me smile a little bit.
I really like your little Serenity can. I run to the can. But even funny things like that will help a patient remember what it is that they might encounter and what kinds of things are important to let their nurses know when they are on these treatments.
Absolutely.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. And today we are joined by ONS member Kris Mathey, GI Medical Oncology Nurse Practitioner at the James Cancer Hospital and Solove Research Institute in Columbus, Ohio, and member of the Columbus ONS Chapter, to discuss treatment of metastatic colorectal cancer. Pfizer provided support for this podcast episode through an educational grant. Thanks for joining me today, Kris.
Thanks, Stephanie, for having me. I'm honored and I'm excited to be here today.
So to start us off today, Kris, can you tell us or talk about how common metastatic colorectal cancer is?
Metastatic colorectal cancer remains the leading cause of cancer deaths, with approximately 59,000 deaths annually. 20% of these patients have metastatic disease at initial presentation, and another additional 25% who present with localized disease go on further to later develop metastasis. Unfortunately, the prognosis of metastatic colorectal cancer remains poor, with a 5-year survival rate of less than 20%.
Yeah, that's so sad. Just that those statistics that you have on with colorectal cancer. And it almost, like you were saying, the number of patients that when they're diagnosed, they already have metastatic disease. It's almost like a silent disease. I don't know if that's a good way to put it, but the fact that you present already in a metastatic level of diagnosis is sad. So if we're talking about this, what patient populations are at an increased risk for developing colorectal cancer?
Absolutely. And you bring up some great points. With one of the great things about colon cancer is we have great screening techniques. So it's unfortunate that patients present with metastatic disease because we can screen some patients earlier for this. We have to think about our modifiable and non-modifiable risk factors in our patients. So we do know that there's some family risk factors, and having a positive family history, such as a first-degree relative, can increase your risk, and screening considerations need to be considered for these patients. Also, men are generally at a higher risk, and their risk increases after the age of 50. There are also some comorbidities, such as inflammatory bowel disease. Now, we also need to talk about some modifiable environmental risk factors that we need to consider, such as obesity or excessive weight or adult weight gain, diabetes, excessive smoking or alcohol intake, and then also the frequent consumption of red or processed meat intake.
All things that everybody needs to really take into consideration, in their daily healthy lifestyle, and just important things for us to remember. But one of the things you mentioned were the family history risk factors. So can you talk to us about those?
Absolutely. With our increase in genetic screening and family history intake that the nurse can be a part of, we can get a really great family history. And with this, over the past several years, we've been learning more about the risk and involvement for colon cancer. So if a family inheritance includes a history of non-polyposis colon cancer, also known as HNPCC, otherwise known as Lynch syndrome, or a variant of Gardner syndrome, or also of FAP, which is familial adenomatous polyposis. Those patients should really have screening early in adolescence, as well as a discussion with a genetic counselor.
Thanks for going over that. I think that's so important. And wow, to think about having adolescents having to already start doing screening and following that, but how important it really is. I'm sure those can get into some really difficult discussions with families. Now that you've told us about all of the risks and things like that, how will a patient present?
Right. So sometimes these patients will present with very vague symptoms. So we have to do a little bit more of a patient history as well as diving deeper into their symptoms. But typically a patient will present with abdominal pain and a change in bowel habits. And when we think of change in bowel habits, it's not necessarily just constipation or diarrhea. You have to think a little beyond more that constipation. Are these patients using a lot of stool softeners or laxatives and having a liquid diet from that with diarrhea related to that? And could this be more from a bowel obstruction? Are they having nausea and vomiting in addition to this constipation, which could also be related to obstruction of the bowel? We also want to question about rectal bleeding and more what this bleeding entails. Is blood mixed with the stool as opposed to blood on the surface of the stool, or is the stool real dark and tarry? In these patients, it's important to do a colonoscopy evaluation if overt bleeding is present promptly. I talk to my patients and I say, you're never going to be looking at your stool as much or as you are now, but it really is an important question and to get information on the consistency of that. Any unexplained weight loss, and this isn't the 2 pounds a week, this is the more like 10 pounds or more in less than 6 months. So really a significant weight loss. Anemia, fatigue, anorexia. Any evidence of metastatic disease would include shortness of breath, cough, chest pain, or even something as simple as what we think of like headaches.
Yeah, it's really good to know what those presenting factors are so that as we're talking to our patients and family members and things like that, that we can advise and help people, encourage them into getting screening done because of how important screening is.
Absolutely.
So a new patient comes in, you have a new patient, and that's what their diagnosis is or what the concern might be. So what would a typical workup be for someone with a suspected or who is diagnosed with metastatic colon cancer?
So if a patient presents with overt bleeding, like I mentioned before, a prompt colonoscopy evaluation needs to be done. Now, we will also have these patients present who have random x-rays of their chest for a cough, and they're found to have a nodule on their lungs or something in their abdomen. And so another part of the screening is you'll want to get a CAT scan that includes the chest, abdomen, and also the pelvis. Also a CEA biomarker and a complete blood count and chemistry, including your liver function tests. On pathology, so once you get a biopsy, if there is anything to biopsy, you'll want to pay close attention to immunohistochemistry with PCR-based MSI testing.
So, hard question now. Is this disease curable?
Absolutely. And that's a great question. For metastatic, oftentimes when we hear the word metastatic, we automatically go to non-curable, which is unfortunate. However, surgical resection can be considered a chance for a cure or prolonged survival in about 10 to 20% of our metastatic colorectal cancer patients. So it's one of the things I like to think is unique to metastatic colorectal cancer. Now, this typically occurs when there's a small number of metastasis or spread to other areas, or the mets are confined to a single organ, such as the liver or the lung. But also, I'll tell my patients, your cancer may not be curable, but it's treatable. And there's some great treatments we have for this.
That's a good way to put it, I think. It may not be curable, but it is treatable. And then giving them that hope that there is the ability to have it treated and still have a quality of life during that time. So what you mentioned, there are other options for treatment. So what are the additional options for treatments with these patients?
One of the other great things, I keep saying great things about metastatic colorectal cancer, is that our treatment options have been expanding exponentially. And we're finding more and more treatments, and really to personalize patient's treatment trajectory. But ultimately, the primary treatment for unresectable metastatic disease is systemic therapy, most of the time with chemotherapy. So first-line therapy is what is utilized initially. And this tends to be interchanged with our second line. So with the first line treatment, if they go on and develop progression or spread of their cancer, that goes on to the second line treatment. And our base of our treatment tends to be fluoropyrimidine, which is either intravenous 5-FU or oral capecitabine with this conventional chemotherapy, which has been around for more than 50 years. 5-FU is given in a combination with leucovorin, which is a folic acid derivative, to potentiate the cytotoxic inhibitory effects of 5-FU. Oral capecitabine formulations haven't been associated with better or worse survival compared to intravenous 5-FU therapy. So you really want to assess in your patients, could potentially an oral drug such as capecitabine be good for them, which they can take a couple times a day, versus taking an IV pump home of 5-FU. So this is a discussion that a patient should be having with their provider, as well as a slight difference in side effects. In frail or elderly patients, 5-FU monotherapy or single therapy is tolerated and typically used. However, for a reasonably healthy patient, this first-line treatment consists of either oxaliplatin-based regimens, such as Folfox or Capox, or irinotecan-based regimens such as Folfox, Folfiri, or Kibiri. These may be administered with or without the addition of targeted therapy. So this is where you have 5-FU and then you add oxaliplatin or irinotecan. Comparisons of Folfox and Folfiri in the first-line setting demonstrated similar overall survival. However, it's important to consider the individual patient and the side effects of these treatments. Oxaliplatin causes more sensory neuropathy, so may not be a good treatment of choice in a patient who plays guitar or has pre-existing diabetic neuropathy, while irinotecan causes more diarrhea and alopecia. So unfortunately, ultimately, most patients end up receiving both of these treatment therapies at some point in their trajectory when either their metastatic colorectal cancer grows or they have a dose-limiting toxicity, which requires switching therapies. Bevacizumab is an anti-VEGF antibody that targets angiogenesis and was the first biologic agent approved for metastatic colorectal cancer and has proven to have a better progression-free survival, but not necessarily overall survival when combined with irinotecan or oxaliplatin-containing chemotherapy in the first-line setting. Bevacizumab does not show any benefit when used alone and is associated with a delayed wound healing and increased risk of bowel perforation. So you need to make sure that it is not used in a patient that is potentially going for surgery or has just had surgery due to this delayed wound healing. So we also have biologic targeted therapies such as antibodies to cellular growth factors. These drugs, such as cetuximab or panitumumab, are only recommended for left-sided tumors with NRAS or KRAS wild-type genes. And wild-type means no mutation in the gene. Cetuximab or panitumumab may be used as monotherapy or, like bevacizumab, combined with our Folfox or Folfiri combinations. Patients with KRAS, NRAS, or BRAF wild-type tumors who have not received an EGFR inhibitor and have progressed on Folfox and Folfiri should receive one combined with irinotecan for third-line therapy. So we have these multiple lines of therapies for a patient. If one doesn't work, we move on to the other one. Another treatment of discussion is immunotherapy. And 5% of our patients present with microsatellite instability, otherwise known as MSI, or mismatch repair deficiency, otherwise known as MMR. It has been found that these patients, unfortunately, do not respond to our traditional 5-FU-based therapy, and immunotherapy may be the best option for them in the first line or subsequent line setting. This immunotherapy has provided improved outcomes with overall survival of 31.4 months in these previously treated patients. These drugs target checkpoints in the patient's immune system that turn off the immune system so these drugs can induce an immune response against cancer cells. Unfortunately, immunotherapy, as I mentioned before, has not been shown to be effective in microsatellite stable or MMR proficient tumors, which are the majority of our patients that have metastatic colorectal cancer. So studies of this is ongoing.
Kris, thank you for that. There's a lot to know and a lot to understand about the treatment options for this diagnosis, that's for sure. You already said that surgery is frequently part of the treatment plan, but what is the role of radiation in treating metastatic colorectal cancer?
So I do want to clarify, it's not frequently part of the treatment plan. It's about in 10 to 20% of our metastatic colorectal cancer patients can surgery be a part. So it's something to be considered and to be seen with a multidisciplinary approach and discussion, but it is something that some of our patients can have. Now, going on to the role of radiation. Radiation is never used as a single modality for treatment. It is used in combination with chemotherapy either prior to surgical resection, or it can be used in the palliative setting for pain treatment. So in the prior to surgery or neoadjuvant setting, radiation is used with fluoropyrimidine-based chemotherapy such as 5-FU or capecitabine, as mentioned before. And these are for unresectable or medically inoperable colon cancer patients to help hopefully reduce the size of tumors of the disease so that they can ultimately be surgically removed. When radiation is used in this setting to help downsize a tumor, we will use a dose of 45 to 50 gray in 25 to 28 fractions. And the 5-FU chemotherapy is ultimately used as a radiation sensitizer. So it's really telling the radiation where to go and how to do its best job. In patients with a limited number of liver or lung metastasis, we can use ablative radiotherapy to the metastatic site. However, this is used in a highly selective cases or in the clinical trial setting. Off clinical trial, however, radiation should not be used in place of surgical resection. Stereotactic body radiation therapy, also known as SBRT, delivers an intense dose of radiation to a certain location. This is something that you want to look at for patients with just one site of metastatic disease, or can also be used for our palliative, so our patients that are in a lot of pain to help in the palliative setting.
Thank you. It really sounds like these patients end up having multimodality treatment options pretty frequently. What advancements in technologies are improving prognosis?
Like I had mentioned before, we have advancements that have been coming. I've been doing GI cancers for about 10 years. And in that 10 years, I can't keep up with all of the advancements. But more and more evidence has been showing the importance of the use of genomic profiling to really tailor the treatment to the patient's individual molecular and pathologic features to improve overall survival. When we look at immunohistochemistry, such as MSI testing, and then you look at molecular profiling and genomic profiling, looking at our patients, as I mentioned before, their KRAS and NRAS and BRAF wild type status, as well as BRAF V600E sequence variations. In those patients, we know that 5 to 10% of those patients have that BRAF or V600E sequence, and that they can be candidates for targeted therapy to this BRAF and EGFR inhibitors, which have been found to extend survival compared to standard chemotherapy. Also, more evidence is coming out with ERBB2 or NTRK gene fusion. You may have heard of HER2 testing being completed on our colorectal cancer patients, which previously we had heard about this more in our esophageal or our breast cancer patients. But one of the great things about doing more molecular testing is we're finding that more cancers have mutations that can be beneficial and respond to other treatments. So the EGFR or human epidermal growth factor receptor, ERBB2, which was formerly known as HER2, is a receptor tyrosine kinase involved in cell growth and differentiation. And the FDA has approved treatments for this, as I mentioned, in breast and gastric cancer patients. However, more studies are ongoing looking at this blockade in metastatic colorectal cancer patients by combining trastuzumab with other ERBB2 targeting agents such as pertuzumab and lapatinib. However, further studies are needed, and this is where all of our metastatic colorectal cancer patients should be considered for targeted therapy, preferably in a clinical trial.
I think the genetic testing that we've advanced to at this point is just so exciting for us as practitioners and clinicians, but also for patients and families to be able to have that more precision, personalized approach to their diagnosis and what is going to actually be a good treatment option and then long-term response for folks. I think that is just so exciting in all of oncology care right now.
I agree.
So talking about the research that's being done and things like that, researchers have explored the differences between right and left-sided colon cancers. Can you talk about that a little bit and how the location of the disease could actually influence the treatment?
Absolutely. And this is something that's really come out in the past couple of years, and it's really being looked at more. And it's so interesting. Previously, we think colon, okay, it's one body organ, it's all the same. But this is really showing us that we really need to pay attention to where in the colon this cancer originates. We do know that about 50% of colorectal cancers arise on the right side of the colon, and these right-sided colon cancers often include more of a mucinous pathology, which happens to be where the mismatch repair pathway is. And this is the primary pathway to microsatellite instability or mismatch repair deficient mutations. So if you think back to where we talked about treatment, these patients can or cannot be more responsive to certain treatments. Also, hereditary cancers such as HNPCC or Lynch and FAP tend to arise more from the right side of the colon. Right-sided colon cancer patients often do not respond as well to conventional chemotherapy. It is estimated that 10 to 15% of all colon cancers arise from the right side, and it is more common in older persons and females with peritoneal metastasis. Right-sided colon cancer has an overall worse prognosis compared to left-sided colon cancer, as I mentioned, and results show a better response to immunotherapies. Now, looking at the left side of the colon, these left-sided colon cancers have pathway mutations such as KRAS, APC, PIK3CA, or P53 mutations. These are more of our tubular villus adenomas that can occur to form over 10 to 20 years. So excision of these polyps are important on our screening. And these are more common of our 70 to 85% of colon cancers that often present in our younger adults with liver and lung metastasis. Our left-sided colon cancers have a better response to adjuvant chemotherapy, including 5-FU and our epidermal growth factor receptors or EGFR inhibitors.
That's so interesting that they are finding the differences between just it being a left-sided or right-sided colon cancer. You think, and I'm sure how many years ago that, you just thought, okay, you have colon cancer, not left-sided, right-sided, and the difference in the prognosis, and also just even the difference in the treatment that you get based on the location of the disease. Very interesting.
Absolutely. It gets very complicated.
It really does. And if that's complicated for us, just imagine how our patients feel. And when they're hearing all of this or trying to wrap their minds around all of this information and what it means for them. And this is just really showing how important it is for us as nurses and clinicians that we need to understand this and have this information so that we can help our patients through their journey with this diagnosis. So you've talked to us about a lot of different options for treatment with these patients that have metastatic colorectal cancer. And you have mentioned some of the adverse events for some of these different treatments as you were going through. But can you talk to us just about what are some of the most common adverse events associated with the various treatment options?
So I tend to tell my patients that all treatments have different side effects, but the one side effect that they tend to all have in common is fatigue. So one of the things we talk about a lot in my clinic is fatigue management, clustering of activities, taking a nap when you need to, but not napping all day, getting up, moving around. I've told a patient, or I tend to tell them, get up once an hour throughout the day. Don't sit watching TV all day. Get up, walk to the mailbox, walk to the kitchen. And one of my patients said, well, I can't walk to the mailbox if it's 3 miles. I'm like, okay. So now I say, don't walk to your mailbox if it's 3 miles away. Just get up, stretch your legs, because the more we sit around, the more tired we actually get. So I think it's important to remind our patients of that. Other frequent side effects we see is diarrhea, especially with our 5-FU-based therapy, which is a mainstay and kind of a backbone of a lot of the treatments that we give. But also irinotecan, when added to that 5-FU, can potentiate or increase that diarrhea risk. When I think of irinotecan, someone that always stayed in my head was I ran to the can. So diarrhea management is important in these patients. Also nausea, vomiting, mucositis. And then I'd also be remiss if I didn't do a quick discussion about peripheral neuropathy in these patients, which is brought on by oxaliplatin. And it's really unique to oxaliplatin in that it initially presents as a cold arthralgia and then progresses into neuropathy. So this needs to be closely managed in our patients. With oxaliplatin, it is a medication that the more doses they get, the longer lasting that cold sensitivity may be after getting their chemotherapy, and it can progress into neuropathy. So if they are having neuropathy, meaning difficulty picking things up, dropping things, buttoning their buttons, tying their shoelaces, that may be cause for a concern and showing me that they're having a little too much toxicity from their oxaliplatin. Nurses also need to be aware of skin rashes with our targeted EGFR therapies, such as panitumumab and cetuximab. These patients often present with an acne-like rash on their face and chest, and it can sometimes lead to infections and be really painful. It can also be really embarrassing. Some of it, our patients will feel like they're going back to being 13, 14-year-old kids with the amount of acne on their face or looking like acne. And it's important to remind them or educate our patients not to use the over-the-counter acne medication, as that can actually do more harm than good. Also, our vascular endothelial growth factor medications use a protein that helps tumors form new blood vessels, such as angiogenesis. So drugs that stop these can ultimately cause increased bleeding. So as I had mentioned before, we have to monitor these patients for bleeding, monitoring them for proteinuria in their urine, and if they're at risk for a bowel obstruction or perforation or going for surgery, we need to be aware of that. Also, side effects of these VEGF inhibitors include high blood pressure. It's important that you routinely check the blood pressure of these patients. It is also important to note that these treatment modalities are often used in combination. So a lot of these side effects don't present just as one thing, but all together. So we need to get a good patient history from these patients, really ask them from one treatment to a next how you're feeling. And also keep in mind that any previous surgery or radiation can play into chronic side effects on these patients. So you may have your previous radiation patients that are having diarrhea from radiation, and then you add the diarrhea effects from radiation or surgery, actually, and then you add the chemotherapy drugs that can increase diarrhea. And this can be a huge issue on these patients. So we need to make sure our patients know to monitor this so we can really help them with their side effects.
Thank you for that. That's so important, like you said, for us as nurses when we're taking care of these patients to know the nuances of these treatments. I really like your little irinotecan, I run to the can. So even funny things like that will help a patient remember what it is that they might encounter and what kinds of things are important to let their nurses know when they are on these treatments.
Absolutely.
So we've talked so much about the diagnosis and the treatment options and workups and things like that. So for patients who have made it through all of these treatments and their first line treatments, maybe even second line treatments. And as you mentioned before, when I asked about is the disease curable, maybe not curable, but treatable. So in those kinds of patients, what would maintenance therapy look like for them?
I love it when I get my patients to maintenance therapy. Like I had mentioned and you brought up again, your cancer's not curable, but it's treatable. And often when patients think about chemotherapy, looking at movies from years ago and TV shows, our patients are bedridden and can't do anything. And that's ultimately not the case. And I wouldn't be doing what I was doing if that was the case, because that's a really crummy quality of life. And we need to think about quality of life in addition to our treatment. And so when we think about maintenance therapy, these are for patients in the first or second line setting who respond to typically Folfox or FOLFIRI for several months and they have stable disease, meaning we're getting CAT scans every 2 to 3 months and their disease isn't progressing. It may not be shrinking, but it's staying about the same, which is ultimately what makes us happy. So what we do is we will take off the more toxic chemotherapy on these patients, which tends to be the oxaliplatin or the irinotecan, and just continue the 5-FU. Sometimes we'll continue this with or without biologics such as bevacizumab, cetuximab, or panitumumab. And ultimately, patients tolerate this really well. And the patients get worried, am I not getting any treatment for my cancer? No, you're getting treatment, but hopefully not all the toxic side effects. And if you remember to previously, when I talked about switching between Folfox and FOLFIRI, sometimes for progression of the cancer, but also sometimes because patients have reached a dose-limiting toxicity, by allowing us to take away that medication because of this stable disease, hopefully their side effects are getting better and they can continue to live their life. And also we continue to monitor their cancer every 2 to 3 months. And if something grows, then we add back that chemotherapy and put them more on the more toxic therapy than the maintenance.
Thank you. That's good to know. And I'm sure it is, as you said, a good feeling to get the patients to that point to be able to be on that less toxic and maintenance type therapy. So can you talk about what is the future for treating metastatic colon cancer? There are so many, as you mentioned, so many new treatment options that are coming out just so fast. But can you talk about maybe what the future might look like?
So advances in metastatic colorectal cancers are constantly evolving. As I mentioned before, the overall prognosis is poor. The advances in diagnosis and treatment options have really enabled us to personalize care to these patients based on their individual molecular profile, allowing us to have some improved outcomes based on these subtypes. So just since 2014, so less than 10 years ago, targeted biologic therapies and immune checkpoint inhibition have really changed the approach to care for these patients. And the future is exciting. And I think that's really where our future is. We're finding more and more of this personalized cancer care on these patients, that we could really expand our immune checkpoint inhibitors and any therapies to really individualize care.
That is very exciting. Always exciting to hear that there's going to be new and better and less toxic, as you mentioned, or less side effects for these patients when they're going through this. So I would like to ask you, what are some common misconceptions about metastatic colon cancer?
Right. This question makes me smile a little bit. When we hear, as I mentioned, when we hear metastatic cancer, we automatically sometimes will think, oh, that's a death sentence. And it's not. As I mentioned, in the 10-20% of our patients that can get surgery and ultimately be cured of their colon cancer. But also, many of these patients continue to live active lives, even with active metastatic colon cancer. So while it's not curable, it's treatable. And we have wonderful treatments and management of our side effects with pre-medications for nausea prior to chemo and also afterwards to help patients really deal with their symptoms so they could continue to lead active lives that they want. It's not a total death sentence. Unfortunately, the prognosis is poor, but we can help with quality of life and to continue to help these patients continue to live their fullest.
Thank you. I think that's a good point. I really do believe that we have come so far with these patients and how we're able to treat them. And really, like you have mentioned a few times, their quality of life, they still are able to have some quality of life. It isn't that they're bedridden and like we used to see and used to think about, especially with this diagnosis.
Right.
So, what is something about this diagnosis that's not often discussed, but you wish people knew more about?
This question makes me smile as I asked my GI colleagues for anything that they thought. And I work with about 8 other nurse practitioners, and I got the same response on this question. And the big thing is young people get it too. So we're seeing that more and more. This metastatic colorectal cancer is diagnosed in younger populations, and we don't know why. It is changing our screening guidelines, but ultimately our young patients who present with anemia or rectal bleeding can't just be pushed off to say, oh, this is just a fissure or a hemorrhoid. We really need to do a full workup on these patients and look into this, as oftentimes these younger patients do present with more advanced disease. The other impact of intimacy for our patients, I don't think is talked about enough or highlighted enough, and not just sexual intimacy, but overall intimacy such as body image, hair loss, depression, fatigue really plays a part in their overall well-being. And this is especially concerning in our patients who have had radiation or surgery. And we need to discuss with them pelvic interventions to help with the side effects of this, such as using vaginal dilators to help. Also, the overall emotional impact of this diagnosis, regardless of age. Well, sure, you could imagine that the diagnosis of metastatic colorectal cancer is shocking and can have devastating impacts on an individual and their family lives. And these patients can initially be really anxious, fearful, angry, depressed. Their lives are suddenly changed. Every time they close their eyes, they're thinking about this darn thing growing in them. And that takes a lot out of them and their families. Families want to come and help them and don't always know how. But we do know that 20 to 50% of our patients show a significant level of distress, which could lead to poor adherence to treatment, especially if this is oral prescribed treatment, and ultimately increased hospital admissions. So one of the things we need to make sure we assess on our patients is distress. And this isn't addressed just on their first visit and 3 months later, but on every visit. So every time they're coming for chemotherapy or immunotherapy, whatever their treatment is, we have some great cancer distress screening tools that are also recommended by the NCCN guidelines. And patients at a moderate or a significant level of distress should be referred for an additional evaluation by social work, counseling, or even a psychiatric evaluation. Because ultimately, and like we mentioned before, quality of life is huge, and we're all only given one life, and we need to make the most of every day.
Those are really good points. That's super interesting that you asked your colleagues and pretty much everybody came up with the right, or the same, not the right, the same. And I have to agree with that. I think that younger people have been, those numbers have been growing from what we have known before. And is it better diagnosing that we're doing now that we're seeing more of those numbers, or is it something different that is causing that to increase? But I also really liked what you were saying about their distress and just the different things that you really have to consider with these patients. Or just have finished ONS Congress, and one of the sessions with a survivor made the comment, sitting in the yuck with the patients. And that just really hit home to me. And I thought, in talking with you about these patients, and they think about it day in and day out because it may not be a curable disease. And it's something that they're going to probably have to live with. Taking the time to check on their distress on all different levels and how they're doing, not just the checking on their side effect management and their symptom management and how the treatment go today, but really getting a little bit deeper and asking those kinds of questions, how important it is for us.
Absolutely. And I think Those questions can be uncomfortable for us as nurses to ask, but the more we ask them and the more comfortable we get with those screening tools, the more authentic it sounds for our patients. And it is ultimately. But as we gain that comfort level, we can't diminish how important overall emotional health is, as well as with physical health.
I can't agree with you more on that. So in talking about all of those things, I just have a couple of questions I want to finish us with. But what additional training or education do oncology nurses need to care for patients with colorectal cancer, metastatic colorectal cancer?
I think that's a great question. Overall, as I had mentioned about diarrhea management, so the way that we treat diarrhea, the way that we grade diarrhea, are they going twice a day, or are they going up to 16 to 20 times a day? Is it watery or is it just loose? Getting a good assessment of that. So we really need to know, do we need to change their chemotherapy dosing, maybe give a dose reduction, or do they really just need something like an antidiarrheal to help them? Also, something that's unique to our colorectal patients and their use of the EGFR inhibitors, such as the cetuximab or panitumumab, as I had mentioned, they developed this rash and management of that rash. I get excited personally when I see they have this rash, as we do know that people who develop this rash often live longer and are ultimately having a better response to this treatment. So that's some hope for us on the provider nursing standpoint. However, that rash can be not harmful, that's not the right word, but embarrassing, detrimental to the patient. So really helping them know how to manage that. Oftentimes we'll start minocycline right off the bat to help diminish the severity of that rash, but also to give them that encouragement. I don't say, oh, if you don't have this rash, you're not responding to treatment. But sometimes if I have a patient that has a really bad rash and we only scan them 2 to 3 months, you know what? I'll give them the little hint that this may not be a bad thing. I know it's painful. I know it's embarrassing and doesn't look great, but ultimately this may mean you're responding better to your treatment than anything else. And giving sometimes that little extra glimmer of hope can really do a lot for a patient. So being aware of that rash is something unique for our GI oncology nurses.
Great. So my last question to you is, what are some additional resources for patients and providers who want to learn more about treatment options that you can tell us about?
Absolutely. So we just finished some great metastatic colorectal cancer education materials through ONS, that those should be available online about mid to end summer. Also, NCCN guidelines, I look at these to help me know what the treatment my patient's getting and what their trajectory is. And then I go up and look the drugs up separately to have an idea. But those are ONS and NCCN guidelines have some great resources for us.
Kris, I just want to thank you so much for your expertise and all of your knowledge and information that you've shared with us today. It's really an important topic, and a lot of patients that do end up having this diagnosis. So just the information you provided to help practitioners and clinicians as they encounter these patients in their treatment rooms and hospitals, this is going to be extremely helpful for them. So do you have any final comments for us today?
No, I think we've covered it all, and there's a lot more coming. So just continuing to be open to education and keep your eyes open for more advancements in this great population.
Thank you for joining me today, Kris.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.